Dear colleagues, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This time we will preview the late-breaking trials at the upcoming TCT 2022 meeting in Boston. My name is Nicolas from Mieghem, and as always I'm joined by my good friend and colleague Joost Daemen for this show. Well, Joost, we're going to discuss day by day?
Day by day, so 3 days of TCT upcoming, starting on Saturday with a lot of focus on structural.
Yes, and I think let's start with probably one of the most anticipated trials, that is the protected TAVR trial. This is a randomized controlled trial evaluating the value of cerebral embolic protection with the filter-based Sentinel device in patients undergoing TAVI. And this is really a big trial. 3,000 patients will be randomized one-to-one to the use of the filter or no filter. And then the primary endpoint is the rate of any stroke at 72 hours. This is going to be important because if the trial is negative, then that might change the spectrum for all the companies that are involved in cerebral embolic protection. And then probably we might start to dive into subsegments of patients, subsets that might benefit from embolic protection, like bicuspid valves or failing bioprosthesis. But if the study becomes positive, then it's going to be a landslide, because then you can expect acquisitions by major companies of cerebral embolic protection companies and so on. So very interesting with a lot of consequences to the trial results.
Yeah, I cannot agree more. Also, to me, one of the trials that I really look out for. I'm really curious about also the sample size calculation. I just did a brief check. If you would need to show a 50% reduction in a stroke rate of 3%, you need 4,000 patients. If you go from 4 to 2, you could meet with 3,000. So I don't know, I couldn't quickly find the sample size for protected TAVR, but this will be an interesting one.
Yeah. So then there's also Clasp 2, and the Clasp 2 is also a randomized controlled trial comparing the MitraClip transcatheter edge-to-edge with a MitraClip versus edge-to-edge repair with Pascal. There are two cohorts. There is a cohort on functional MR, there's a cohort on degenerative MR, and this presentation will focus on the Clasp 2D study, which focuses on degenerated mitral regurgitation. Patients were eligible if they were at inoperable risk and obviously by default had degenerative aortic stenosis. So we'll see how many of those 1,200 patients that were envisioned in the overall Clasp 2 study protocol will end up being in this subset of 2D. That it's a non-inferiority study, both in terms of major adverse events and in terms of MR reduction. And so we'll see what's going to happen. I find, from our own practice, today we coincidentally did both a MitraClip case and a Pascal case. I wouldn't know which device would have the edge. I think it's good for the field, for transcatheter edge-to-edge repair, to have multiple technologies available. Again, we'll have to see what the results.
Yeah, no, I agree. And at the end, I think there will also be a learning curve. And I think most physicians will have more experience with MitraClip than with Pascal. Yeah. So I'm curious to see how that will turn out in the study and if there will be any focus on a procedure time, etc. But I expect non-inferiority.
Well, and on top of that, and because those are very appropriate comments, because we will discuss Amulet IDE later on, that something similar happened there with Watchman and the Amulet for LAA closure. But in this study, Clasp 2, also the question is, okay, what kind of device iterations were used? Have they been using the latest generations? Because we are already at the 4th and 5th generation of the MitraClip, and obviously that also plays a role in procedural efficacy. Yeah. So more on transcatheter edge-to-edge repair. There is a large registry, or a registry derived from the TVT Registry in the United States, where they focus on the value of TEER in cardiogenic shock. I think this is very interesting because we are facing patients at high mortality. And I wonder how large the sample size will be, and also what would be the mean age of the patients, and what is the MR etiology? Will we see predominantly functional MR, or is there also a good proportion of degenerated mitral regurgitation? Obviously, the patient heterogeneity will affect the analysis and the interpretation, but I think it's fair to say that definitely not every patient in cardiogenic shock should undergo a TEER procedure. So how did they interpret the patient demographics? That's going to be an interesting one. And then obviously, I think if you do proper patient selection, then probably TEER should work in cardiogenic shock too. But there is this flip side. If patients are too far out, if the ventricle is overly dilated and is really massive mitral regurgitation, then you may have turned the point of no return. And then the question is whether you still should do a TEER. We know from our own pressure volume loop analyses that some of these ventricles, as you are clipping them, they really get into trouble, and you see changes in pressure volume relationships that already anticipate problems down the road. So we'll see what happens in that registry.
Yeah. Interesting concept, but I'm afraid as I see it in the future, an option for only a handful of patients. I mean, these patients most of them are far out, and this is not a simple, small, cheap procedure, right? I mean, it's invasive. Anyway.
Talking about a niche, there is also a registry upcoming from the UK this time that is looking at post-infarct ventricular septal defects. And, you know, I think we have 5 to 10 of those patients per year, and there is this eternal discussion: when should we intervene? Should we intervene? And when should we go for surgery? Because surgery can be an issue. There is not enough good tissue to make sutures for the surgeon. And at the same time, when we would try to close it with closure devices, then the question is, okay, but what would be the size? What would be the type of closure device? And then there are also the issues of residual leaks and hemolysis. So this is, again, a very interesting registry. So how many patients were they able to include? What is the mean age of the patients? What kind of devices were used for percutaneous closure? How many patients underwent attempted surgery? And then the endpoints at 30 days, 6 months, and 1 year. I don't think that the mortality at 6 months is low in that set of patients.
That's for sure.
Okay, and then I already mentioned the Amulet IDE trial. So the Amulet IDE trial is a randomized controlled comparison between LAA closure with the Amulet device or the Watchman device. And the primary outcome of the study was already presented and published in Circulation in August 2021. We're talking about more than 1,800 patients, 1-to-1 randomized, and the primary endpoint at 1 year was basically a composite of safety and efficacy. They were looking at bleedings, but also at death and procedure-related complications. And there was no difference if you look at that primary endpoint between the two strategies, although there were more embolizations, device embolizations with Amulet, and also more pericardial effusions. And that is probably reflecting the early experience with Amulet and the more experience, the higher experience with the Watchman device. And then there was also another endpoint. That was the efficacy endpoint in terms of stroke or systemic embolisms. No difference between the two strategies. And there was also a third endpoint, and that looked at LAA occlusion at 45 days by TEE. And it turned out that the Amulet had a higher likelihood of complete LAA occlusion. Now, the question is, how will that translate down the road, up to 3 years after the implantation? And that is exactly what this presentation will be about. And so we'll see how this difference in LAA occlusion will translate in terms of new strokes. My guess is there won't be a difference.
No, I think it's a large trial with a, as mentioned, significant sample size. But yeah, we are comparing the incidences of events that are relatively rare, specifically post-device implant. But that said, and irrespective of the potential differences between the two technologies, I think the trial is of interest, specifically because of the long-term outcome in a large series of patients properly following LAA closure. So that that by itself, I think, warrants a interesting presentation.
And we should also bear in mind that the patients who were eligible for the study needed a rationale to seek non-pharmacological alternative therapy. So it is not that we're talking about patients who could not tolerate oral anticoagulant drug therapy, for instance. So from our perspective in the Netherlands, we face issues with reimbursement of LAA closure. That is very relevant because we're not talking about patients who cannot tolerate oral anticoagulant drug therapy. So anyway, we'll definitely come back to that in our wrap-up. And so the last trial on Sunday is SCOPE 1. Also there, 3-year outcome data. SCOPE 1 was a randomized controlled trial comparing the SAPIEN 3 with an accurate neo valve. More than 700 patients were enrolled, and it turned out that for the primary endpoint, which was also a composite of a safety and efficacy at 30 days, the accurate neo was inferior and the SAPIEN 3 was superior with more paravalvular leaks in the accurate arm. There was no difference in mortality, although the hemodynamic valve performance with the accurate,
was better.
Being a supraannular valve, was better than with SAPIEN. Yeah. So then the question is, okay, so how will that translate in outcomes at 3 years? Will the hemodynamic valve performance prevail, or is paravalvular leak something that will haunt the patient down the road? I don't know. I think we'll see no difference in mortality at 3 years.
I tend to agree. I think 3 years is too short, but who knows what will happen at 5 to 10 years when potential durability issues related to the gradients will interfere in the result.
But it also adds perspective to these early outcome trials, right? Because absolutely. Everybody was very negative on the accurate neo platform because of SCOPE 1 and SCOPE 2, and that was driven by an increase in paravalvular leaks. But if you then look closely at the data, it was not, those trials were not the best trials in terms of trial execution. There were a lot of missing data. Also in follow-up, there were a lot of missings. And we know with supraannular valves, with a nitinol frame, that might change in terms of paravalvular leaks down the road because the nitinol might expand a little bit further. So anyway.
But also in terms of a device per se, now with the Neo 2 and the ceiling skirt, I think the whole concept of the PVL discussion changed again. And so it also adds some nuances to the impact that these data will have.
So on Sunday, finally, we have again some renal denervation.
Absolutely.
Some hypertension studies.
So long awaited at TCT this year, Sunday, 11 a.m. Our friend RJ Courtney will present the results of the Radiance 2 IDE pivotal trial. So as you recall, the Radiance 2 trial is now the third sham-controlled randomized trial in the spectrum of the Radiance pipeline, assessing the safety and efficacy of the Paradise ultrasound renal denervation system in patients with hypertension. So Radiance 2 is now the first trial that was actually powered for safety and efficacy and followed solo as a trial assessing the performance of the technology in patients with mild to moderate hypertension. So individuals on 0 to 2 drugs that were taken off their drugs prior to randomization and then being withdrawn of these drugs, assessed for a primary endpoint of systolic ABPM at 2 months. So the trial leadership already announced the press release on July 26th that the trial met its primary endpoint, being a 6 millimeter difference in the primary endpoint of systolic ABPM at 2 months. But now, during this presentation, we'll hopefully learn more about all the ins and outs of the findings, the safety, the durability in terms of daytime, now time, blood pressure decreases, etc. in a total of 225 patients. So I had the pleasure to be involved in this trial, and it was a challenge. The trial was developed in 2018 and ran throughout the full COVID period, but with the help of 60 sites, we managed. And I think it attests to the endurance and involvement of all the people within this trial.
And the endpoint is when? At 30 days? At 1 year?
2 months.
2 months.
2 months.
Oh, okay.
Yeah. So RDN, ultrasound RDN versus sham in patients taken off drugs.
So there are no drugs.
No drugs within the 2 months of assessment of the primary endpoint. Yeah.
Okay. Good.
More on RDN is the, directly after the presentation of Radiance 2 is the data, 3-year data actually, of the HCN3 trial. So as you recall, HCN3 was the negative trial that Medtronic performed now already 8 years ago, published in the New England, 530 patients, RF, renal denervation versus sham in over 500 patients, 1-to-1 randomized. Trial missed its primary endpoint, merely showed a 2 millimeters difference in ambulatory blood pressure at 3 months. Trial was criticized a lot, but at the end formed the basis of these newer generation trials like the on and off med trial from the Spiral program, the Radiance program, which then at the end 5-6 times in a row turned out to be successful. And positive. This trial failed to meet its primary endpoint. However, now with the 3-year findings, I think the data are of interest because it will add a little bit of perspective to the durability, but obviously in light of changes in drug therapy, compliance to the drugs, and the execution of the trial with changes in crossover, etc. So perhaps somewhat complicated to interpret data, but I think still of interest in this era.
Yeah, it's fair to say that there is renewed enthusiasm in
that is for
renal
sure.
denervation, and hopefully at one point we'll also get it reimbursed for commercial use.
Absolutely, yeah. And that was also obviously one of the reasons that the IDE trial of RECOR now, which is now being submitted for a PMA in the US, but that will take time. And along these lines, it will also take time in Europe and in the Netherlands. But I'm confident at the end we'll get there.
Yeah.
One more study on denervation, in this case pulmonary artery denervation, presented by our Chinese friends, studying whether pulmonary artery denervation is superior to a sham control in patients with pulmonary artery hypertension, defined as a mean POP above 25, wedge below 15 and a high PVR. 126 patients, 1-to-1 randomized to a general EP catheter-based pulmonary artery denervation plus phosphodiesterase inhibitors or phosphodiesterase inhibitors plus sham, with a primary endpoint of 6-minute walk test. Of interest, the group of investigators already demonstrated the validity of a concept in a single-arm study published several years ago. This is the proof of the pudding in the randomized concept, so I think of interest.
We're talking about a dedicated system with radiofrequency ablation?
It's a radiofrequency system, but as I recall correctly, it's a routine commercial EP catheter. Oh. So one that you would use for pulmonary vein isolation. But it's a conceptual study, but I think potentially of interest. Then, stepping a little bit away from RDN, another trial that is of interest to us, I think, on Sunday is the Universal trial. So Universal, as you recall, is the multi-center randomized controlled trial assessing the superiority of ultrasound-guided femoral artery access in patients undergoing coronary angiography. Patients in a total of 621 to 1 randomized to either ultrasound or angio-guided femoral artery access, but now powered for a primary endpoint of BARC 2, 3, or 5 bleeding. A potentially interesting trial that could have implications to the guideline adoption of the recommendation of using ultrasound. So, I mean, I don't have to convince you. I mean, most of us are using ultrasound now for many years as their default strategy in gaining a femoral artery access, both for small as well as large bore access. But the data supporting that is scarce. The only one, I think the only big trial I know is FAUST 10 years ago, which actually failed to meet superiority of ultrasound-guided access in achieving a common femoral artery puncture. However, the trial did demonstrate a lower rate of complications in the ultrasound-guided group, but no significant difference in bleeding. So with that, I think the results of Universal are something to look out for.
Yeah. At the same time, it's only 621 patients, yep. So the sample size might be a little bit optimistic. And we're talking about small French systems, right? It's not large bore catheters. So it's gone.
I tend to agree, and I also have I'm not so confident that this trial will be positive, specifically since what we learned from FAUST is that there's also a specific learning curve, and it's not said that all of these sites were experts in femoral artery access, at least not as far as I know. So we'll see.
Yeah, and I remember like 15 years ago, I was also critical about having to use ultrasound for all my punctures, but at the same time, it doesn't even add time to the procedure these days, because if your logistics is built around ultrasound guided access, then it shouldn't take too much time.
That's for sure.
Yeah. Then maybe a brief note on the FLASH registry.
Yep.
FLASH registry is a registry in an interesting set of patients with pulmonary embolisms, but we're not. It's a thrombectomy system, large bore catheter. It's 24 French, and it involves patients who are with intermediate and high risk pulmonary embolisms, and that is a little bit of an issue from a European perspective, because obviously our guidelines do not recommend embolectomy in patients with intermediate risk pulmonary embolisms, only in the high risk subset of patients. But still, this registry reached its completion of 500 patients. They have a major adverse event as primary endpoint at 48 hours that includes all kind of device and procedure related adverse events. There was already a preliminary analysis on 230 patients a couple of years ago that gave a hint of favorable effects on hemodynamics and RV decompression with no safety issues, and I don't expect anything else. I think it is really an important add-on to the existing armamentarium. I would agree with lowering the thresholds to consider patients for embolectomy, for catheter-based embolectomy, but I think we may need a little bit more robust randomized controlled trial data to support it.
Yeah, I agree, and I think there's a lot of momentum now for the technology. I mean, I recall also at ESC a couple of weeks ago, a lot of focus on the technology. But it's a field we still, I think, are developing in terms also of the appropriate endpoints to demonstrate efficacy. Is that echo? Is that clinical? Is that PA catheter-derived metric? So I think something that is of interest.
What about Monday?
Yeah, Monday, a couple of trials we wanted to highlight. One is the 10-year result from the BEST trial. So you recall BEST was published in New England 2015, was the successor of Syntax, so a randomized controlled trial comparing PCI with second generation DES, Zynes in this case, compared to CABG in patients with multivessel disease. So this was a trial from Southeast Asia that aimed to enroll almost 1,800 patients, but was stopped early due to slow enrollment. So the results published in New England were actually based on a sample of 880 patients, if I'm correct, which showed at 2 years no clear differences. However, at 4.5 years, a superiority of CABG as compared to PCI with Zynes, with I think differences of 30% more event rates, death, and MI stroke at a mean of 4.5 years. So that's also a little bit what I expect for the 10-year findings. You will expect, at least I would expect, a higher rate of repeat revascularization in the PCI arm. And with respect to death and MI, we've learned from Syntax and even meta-analysis that we've performed in the past that there is a slight increase and a slight persistent increase, I should say, in long-term risk of mortality in favor of CABG as compared to PCI. So we'll see. Interesting data, but I do not expect any peculiarities here.
I would be surprised if we would see a mortality difference between the two arms, because at 10 years, it depends on the mean age of the patients who were enrolled in the study, but at one point, patients will come to die. So then it becomes very difficult to see a difference. So I would be surprised if there is a mortality difference. And I think it's interesting to learn whether between 5 and 10 years we still see an increase in a higher need of repeat revascularizations in the PCI arm. So I like that, because this is then the first trial using these latest or later generation drug-eluting stents with a 10-year follow-up. So yeah, interesting.
Good. More on coronary FAVOR3. Also, again, longer term findings, I should say. 2-year findings from the FAVOR3 trial. So you recall FAVOR3, to me, a very interesting trial. Chinese study randomizing 3,800 patients to QFR-guided revascularization strategy versus angio-guided PCI. So the trial was overwhelmingly positive, I should say, at 1 year, showing a significant decrease in actually almost any of the endpoints. So lower rates of MI and repeat revasc mainly in patients undergoing QFR-guided strategy. That at the end was due to the fact that patients in the QFR-guided arm underwent less PCI, so that translated into a lower rate of periprocedural MIs that were counted in the primary endpoint. How that will translate at 2 years, there was no clear separation of event rates over the time, so I do expect that there will remain superiority of the QFR-guided strategy over angio-guided PCI. Specifically since the percentage of patients in which the treatment strategy actually differed was only 10%. So I would be surprised if there are any particular new findings that would surprise us.
So there's a lot of research activity in the space of angio-derived FFRs or QFR, VFFR. So can you bring this trial in perspective of FAST3 that you're running?
Yeah, so this was the first large-scale outcome trial in looking at the potential for angio-based FFR, but obviously there are more. So there is with the same technology FAVOR2, which is now ongoing in EU and Japan. Well underway, but there's also the FAST3 trial, which is a similar concept as compared to FAVOR2, in which we will look at, in this case, VFFR-guided treatment strategy, however, with FFR as a competitor. So those are the critical differences, both in FAVOR2 as compared to, and FAST3 as compared to FAVOR3. Both are non-inferiority. This trial was a superiority trial. So I think the trials will all add to the body of evidence on the use of angio-based FFR, and I think that adds to the interest in the technology, and hopefully will drive guideline adoption at some point.
But FAST3 basically is the next level, right? Because it compares angio-derived FFR with wire-based FFR.
Yep.
And so that is definitely next level, because we already know that coronary physiology improves outcome versus angio-guided PCI.
That is correct.
All right, so that is a preview of the late-breaking trials at the upcoming TCT meeting. We both are going to Boston 2 weeks from now, and afterwards we'll come back with a wrap-up of all the interesting trials that we just presented.
Thank you for watching.
Bye.